Good evening, colleagues. Can you all hear me?
Please proceed.
All right. Welcome to today's session. So the topic has been changed beyond recognition from healthy children to common pediatric surgical condition. So our presenter is Moforo. He will take us through. Over to you, Doc.
Are we seeing it? It's not good. Okay. Oh, thanks. Good evening, colleagues. I hope you can hear me loud and clear. As Dr. Love said, today's talk has been changed from management of pains to common pediatric surgery conditions. I thought this would be a more ideal discussion because it is going to cover a lot of pediatric conditions that we meet in our daily practice. So for most of the conditions that we see in babies are from trauma, burns, foreign bodies. We also see quite a lot of growing surgery, neonatal surgery, acute abdomen, and also there are a lot of head and neck lesions, which I'll try to clarify and suggest how we should be able to go through them every day. So I'll start with hernias. The most common surgery that we do as pediatric surgeons is hernia surgery, mostly umbilical hernia and the indirect inguinal hernia. But there's also an element of the direct inguinal hernia, epigastric hernia, incisional hernias, as well as femoral hernias. The indirect inguinal hernia is the commonest one that we operate on, and its pathogenesis is due to a patent processus vaginalis. It can be divided into the ones that are complete and the ones that are incomplete. It's also found in girls where the content is usually an ovary or even a fallopian tube. If you are to encounter indirect hernia in a pediatric female patient, what you must be worried of is the fallopian tube may form part of the wall. So while you are mobilizing it, you may actually chop off the fallopian tube if you are not worried. So this is a technical point that we must all be worried about if we are exploring an indirect inguinal hernia in a female patient. Okay. So the direct hernias form, like I said, by far the majority of the hernias that we see in pediatrics. 1 to 3% of the live birth present with an inguinal hernia at some point. percentage rises if they are preterm, and the right side is by far the commonest side, with the left side being like a half against the right side. And in about 10% they are bilateral, and the bilateral are even more common in girls. And generally speaking, the ratio between boys and girls is 6:1, although different literature will give you numbers up to 10:1. I think it just depends on where you are practicing. So the patient present to us is of paramount importance. We need to know which of the patients with inguinal swelling are hernias, and which ones from the other differential diagnosis list. But the presentation is not going to be the same. The size, the duration is going to be different, but it's generally going to be a bulge in the groin, even going into the scrotum or into the labia. And almost about 50% will present in first year of life. Others will present a bit later. Some patients may actually present because the caregiver comes and gives a history of this mass that keeps coming and going back. But on examination, you don't find the mass. What to do for the practitioner becomes a challenge then if the patient presents without the mass at that point. But some studies have found that you are unlikely to have a negative finding if the parent gives you a good history, or if you ask the parent to take a picture of the hernia on the next time that it comes, then you can use that to operate on the patient. The neonates and the premature have got the highest risk of complications. What we must then do is to have a differential diagnosis of these patients. Some of them are just lymph nodes, maybe at times from injuries on the feet, in lymph nodes from systemic disease. It could be an abscess. It could also be an undescended testis. It can be hydrocele. It can also be a femoral hernia. That the fact that we mentioned a hernia there is important, because then in that region you could get a femoral hernia, you could get a direct hernia, you could get an indirect hernia. So the three of them are managed in totally different ways. So you need to be clear which kind of hernia you are dealing with there. So what is the problem when we get a child with indirect hernia? The problem is in incarceration. The incarceration, like we know, it is one that does not reduce spontaneously. The strangulation is one with the vascular compromise. And for anyone who struggles to remember these two, is the way I was taught in medical school was to remember, if a prisoner is put in prison, they are incarcerated. But if they are going to be killed in the prison, then they are strangulated. So the one that is just in the bowel, that is just in the hernia, is just incarcerated. But one is dead, then it's got vascular compromise and seen strangulated, and this also leads to bowel obstruction. And if it's not done, then this will lead to bowel perforation and leading to septicemia and shock. And one of the patients that go into septicemia and shock, what the organs is infected, which is the testes, and we would not want the patients to lose their testes in this fashion. So we go out on the management. What we must learn from this slide is that these indirect hernias, they never could close spontaneously. So at no point should we promise our patients that we are going to review these hernias yearly or something and wait for them to close. They are never going to close. They are only treatment. People have done large studies to see if they are convincing, like 1 in 10,000 who close. We really doubt if there is anything like that, or the ones that were found to close, if they were years to start with. So the timing of when do we close them, it depends on the presentation. But the ones firstly, the ones that have incarcerated, they need to, then you can reduce it and book it elective. But what we must learn is, if we have reduced it, we must not then discharge the patient, because once it is incarcerated, it is likely to incarcerate again. So we reduce it and admit the patient and wait for 48 to 72 hours, and then we operate on the patient electively. The ones that are strangulated with obstruction need to be resuscitated and operated subsequently. What are the complications that we find in this kind of patients? There are quite a lot of complications from the surgery of these patients. They can be cord and vascular injury. They may be hematoma, infections. They may end up with a hydrocele or even worse still, they may end up with a vanished testis. So the complications are particularly important if one surgeon is going to operate on this patient bilaterally. If the surgeon is going to operate bilaterally, then the surgeon must be competent in this kind of operation, because then if the patient ends up with the infection of both testes, then that will be a total disaster for the patient. So this must be taken into account to a point that previously the recommendation was the one surgeon must operate the one side and the other surgeon must operate the other side. But with the advent of laparoscopy now, the injury to the vas has been well done away with, because you can operate on bilateral or unilateral hernias and under clear vision using a laparoscope. The advantage of using a laparoscope in the operation of hernias is you firstly you can make a firm diagnosis that this is an indirect hernia, not a femoral, not an a direct hernia. Secondly, you can and have a look at the opposite side and see if there is a hernia on the other side, and repair it at the difference between the viscera from the peritoneal space for the viscera to go down. So only fluid that comes from the peritoneal cavity down into the patent processus vaginalis, going either into the groin or right down into the scrotum, depending on what kind of process vaginalis the patient is. This slide will just remind us, we deal with adult patients every day, that the pathogenesis of this hydrocele in an adult patient is totally different. It can still be congenital, but most of the adults, it's usually from infection. Hematomen like to cause a lot of drama amongst themselves. So trauma is also a big cause, and also post-surgical. So, like I said, non-communicating. And the old method that we learned in medical school of trans-elimination is is still.
All right. Sorry about that, team. Let me just try and confirm with the presenters because he seems to be having troubles with the network. Can we just ask for a bit of time, a few minutes to sort out and clarify the issues? Thank you.
Diagnostic. But one thing we have seen a couple of times is how this must not be done by any. So how
Okay. Do you hear me on this alternative microphone?
Do you
Yes, you are audible, Doctor. It's just that you are cutting at some.
Do you hear me on this microphone?
Yes, I can hear you clearly now.
So they don't hear me. Do you hear me now?
Yes, you are audible, Doctor.
Oh, okay. Okay, thank you. Very sorry about that. We used an alternative microphone now.
Okay.
Okay. Okay, I think I've gone through how we manage inconvenience. This is the message there was clear that they never resolved spontaneously. A neotomy must be done. I've already emphasized never to aspirate this. And the timing of the operation is age dependent, the size and the associated conditions. I would give an example of a preterm unit in ICU. The baby has got contrasting problems. It's got respiratory issues, it's got possible cardiovascular issues, and nutritional issues, and then the patient at the same time has got an inguinoenia. Then when to operate, it has to be individualized because of the condition of the patient. The next thing I will discuss is the undescended testis. This is an absent testis in the scrotum at the birth. So,
sorry, Doctor, could you please advance the slides? They seem to be lost.
And now I just try to advance once and go back to my slide. If they move now, the one that I'm looking at is the undescended testis.
No. Could you just maybe upload them so that everyone can see them like we were seeing them before?
All right. Okay. Do you see where we are at now? Now we are at an undescended testis slide.
Try sharing the slides again, Hotel.
Hi, Doc. It must be the slow network. Are you able to project from your end?
We don't have the slides, the presentation.
Okay. Pinda has.
Are you able to share screen?
Yeah, we're sharing screen.
Oh, okay. Maybe Mosima can project from that side if he has them. Okay, they are showing.
Okay. So are we at the same slide? At the undescended testis slide?
Yes.
Okay. Okay. Sorry about that. So an undescended testis is one that is absent from the scrotum at birth. So on examination, the scrotum is empty, and this is found in about 2% of boys at birth. But the interesting thing is, over the next year, most of these will descend and become palpable. So that by 1 year, it's only 0.8% that are not palpable. So the teaching is then in the first 3 months we do not operate on these babies because the management is expectant, and afterwards, if the surgeon is very good with this with this kind of operation, then they can operate at 6 months. But if the surgeon is not very confident with this kind of operation, but this can then be operated at 1 year when the structures of the testes are bigger and can be recognized easily. And it is important that we recognize the testes that are retractile. The retractile testes are ones that at times they are found in the testes, but then they still some of the time they're not resident in the testes. So it is important to recognize between these two. There is also another group of testes that are called ascending testes, but the real difference between the ascending and the retractile is not clearly defined. So where do we look for the testes that we can find? We look for some are in the abdominal cavity, some are in the inguinal canal, some are actually ectopic. The ectopic ones are these ones that are on prepenile in the superficial pouch. Some are on the transverse scrotal, some are in the perineal region, and some are in the femoral area. But having said all this, what is the useful definition that we use in regard to unintended testes is what we need to do is to find out, is it palpable or is it non-palpable? If it's palpable, then it goes to its own algorithm of management. If it's non-palpable, it goes to its own algorithm of management. And sorry, I'll go back to that slide. It's also very important that some of these testes have been there, but they vanish post-torsion. The ones that vanish post-torsion, especially if it has been a neglected torsion, those ones we can't do much about them. But the ones that disappear post-anatomy are our problem. It means it's the surgeon who has caused the vanishing of these testes. So we must not, whenever we operate on this, we must make sure we don't cause ischemia to the testes, and the patient ends up with a vanishing testes. So the problem of the patients with undescended testes is if they are bilateral, then the patients are almost always infertile. But if it's only unilateral, then about 25% are infertile. They are also prone to trauma wherever they are. If they are not in the testes, if they are not in the scrotum, they are also more prone to torsion. And the risk of malignancy, if the testis is in the peritoneal cavity, rises by 20 to 40 times. And also, it causes a lot of psychological trauma to the patient as the patient grows up, if this is not attended to, as well as the caregiver. The management is an okidopexy. That's the standardized money management. Over the past 2 months, I've seen 2 patients that have been referred by some practitioners with for because they could not palpate the testes, so they thought they are not there at all, and some even suggested hormonal, if you could consider hormonal therapy. Hormonal therapy has been abandoned because its effects are hugely debatable, and we do not think the hormonal therapy must be administered to these patients, and also considering what the side effects of the hormonal therapy to these patients. Imagine giving hormonal therapy to a 1-year-old, and then the testis is not coming down. You continue giving hormonal therapy. The patient starts to have pubic hair. The patient starts to have large organs and axillary hair. It's not. We do not recommend that this kind of treatment is still used on this patient. And if the patient presents after puberty, then the recommendation is to do an orchidectomy, because the risk of malignancy is very, very high. So, like I said, what we use now is the testis palpable, or is the test non-palpable? If the testis is palpable, then most likely we can operate the testis openly from the groin and mobilize it into the scrotum. If it's not palpable, we must not then conclude that the testis is absent. The testis may still be there in the abdomen. The next question that people ask is, what is the role of imaging? We have seen lots of patients with a lot of ultrasound scans to try to see if they can find the testes, and most of the time the ultrasound scan says there's no testes, or they see something that looks like a testis, when very few people want to commit themselves that they can see a testis there. And so the standard management of these patients is not to image the patients. The role of imaging in these patients is to image the obese boy who you think probably you have examined. You do not think you can palpate the testis, but you think it may be around the inguinal region. Then you can use an ultrasound scan. But otherwise, the ones that you are not able to palpate, they should be explored laparoscopic to find if they are there. And it is also important to note that it's not always that they are there. Some of them may actually have been you have tossed intrauterine, so the testis may be there. The testis may not be there, or you may find that the testis has already gone into the inguinal canal, and then you use the appropriate algorithm. So much about the undescended testis. The next thing I will discuss is the acute scrotum. The acute scrotum is a nightmare for anyone, because you want to quickly decide in the first few hours that you're seeing this patient whether this is a torsion or a torsion. So it's torsion, and then the other things we will think about after that. We want to see if is this a torsion, and if this is a torsion, it must be managed urgently. The guideline is within 6 hours, but naturally we want to do it as soon as possible. The different diagnosis, like epididymitis or ochitis, then we tend to confuse you. And but if it's an ochitis, obviously the management is antibiotics, and you wait until the patient gets better. If it's from trauma, usually you have a history. But for these young boys, at times they are scared of the consequences of admitting that they were playing with their friends and got kicked. So they will give you a misleading diagnosis of trauma, or vice versa. They may, for a testis, they may even give you a trauma that was not even there. Then there comes some other things like an idiopathic scrotal edema that needs to be differentiated from a toast testis. But if from this list, I think what we need to discuss then is a toast testis. What must we do? Once we get a patient with a torsion, should we operate on it even without an ultrasound scan? If we cannot access an ultrasound scan within the next few hours, and we are not sure of what this is, then the investigation of choice is not an ultrasound scan, is not an MRI, is not a CT scan. The investigation of choice is then an exploration, because an exploration is going to save these testes and as well as fix the contralateral testes. So we must not be scared of exploring the testes. This is one of the tools that we must use frequently if we are not sure about the diagnosis. Otherwise, if there is time, if the patient presents in a time-massly manner in the first hour and we've got an ultrasound scan next to us, then we could even just use an ultrasound scan to make the diagnosis. So the investigation is mainly the clinical exam. In some other places, the nuclear scan is readily available. Then you could use the nuclear scan, but I'm sure in our setting we are not going to find this nuclear scan anytime soon. So what we need is a clear mind that if we do not rescue these testes, we are going to lose it. So if there's no investigation and you got a high suspicion, then exploration is the tool to use. After 6 hours, then there's going to be progressive loss of tissue, and then we are not going to be able to save these testes. So if there's anything that we learn on this slide is management is scrotal exploration, and scrotal exploration is what we must learn on this slide. We move over to umbilical hernia. This is one part that I'm sure many of us are left with so many questions when the caregiver presents this kind of patient. We tend to ask ourselves, is this patient should we operate on this patient now, or should this patient wait? So the guidelines that I will say now are that for umbilical hernias, what we must learn is like that strapping procedure that was previously used. People used to strap all sorts of things, including coins, onto the umbilicus. Those do not work. Some people used to think that it works, but it is because the umbilical hernia, most of the time, it closes on its own. So that coin was an innocent bystander while the umbilical hernia was closing. So the incidence is about 3% in the newborns, and by 3 years of age, most of them have closed. So this is what we must learn from this slide. I think that we must all these babies that we see with these umbilical hernias, most of them look quite dramatic, but we must know that we give them until 3 years of life for them to close, unless, of course, if they incarcerate. If they incarcerate, then they must be operated. Once they incarcerate, they are likely to incarcerate again. So the treatment for one that is incarcerated is to reduce it. Usually they're very easy to reduce. You reduce it, admit the patient, and operate on the patient electively. And it's also interesting that when they get smaller is when they are likely to incarcerate, because when they are large, the bowel can still move in and out, but when they are small, they tend to trap the bowel, especially in times when there's increased abdominal pressure. One simple thing that we may find is that that child with an incarcerated umbilical hernia also has got an upper respiratory tract infection. The persistent coughing tends to incarcerate the bowel. So the problems with it by far is the cosmesis. That's why the caregiver will keep coming to pressurize you that let's close this now, because everyone, the child's age mates are looking at it. I even remember some girl that we grew up with, everyone was always talking about a large umbilicus, and I'm sure until she grew up, she was quite traumatized by this. So incarceration and strangulation are the things that are life-threatening. A few may actually end up with evisceration of their bowel, and we've actually there are some that grow into adults, and then when they are pregnant, then the hernia starts to give them the problems. So, like I said, they must be, if they don't strangulate or incarcerate, the guideline is to operate them at 4 years. Otherwise, they except for one kind of hernia, one that we call a proboscoid hernia. The proboscoid one is one that is very large, that tends to, it does not tend to just come out like in a horizontal plane. It comes out in a horizontal plane and then like sort of looks down to the patient's feet. So it's a very large one. That one has very little hope of closing. So that one we must close it as soon as possible because of this cosmesis that I've already emphasized, the psychological trauma to the parents. And the other point is we must close them before these children go to school, which is by now that they start creche earlier. After 3 years, we must just close them because like the boys tend to use this kind of uniform that the other ones are putting on the t-shirts. The other team takes off the t-shirts to make a new uniform. So these ones, that's when they start probing other people's body features, and it's not going to be nice if they keep probing the adults umbilicus. So they must be closed by this time. So this is one of the considerations, that by the time they go to school, they must be closed so that there are no issues. Also of note is that these umbilical hernias can be also associated with trisomy 13, trisomy 18, and with also Beckwith-Wiedemann syndrome, Ehlers syndrome. The diagram is quite simple. It just shows that it's just the bowel that is coming in, and when you push it, even the mother will tell you there's been a gargling sound all the time. This slide just shows all those complex 1 centimeter by 1, if they are 1 centimeter by 1 year, 2 centimeters by 2 years. Those are guidelines. But what I said supersedes everything. If it's not closed by 3 years, is when we must close it. So the hernia repair for this patient is by primary repair, always by primary repair. There's no role of a mesh in these small patients. The next hernia that we'll discuss is the para-umbilical hernia. This is a totally different to an umbilical hernia. Even if the management is, there are different management points. I will mention the most important management point there. This one is from a defect in the linea alba, and if you on examination, most of the time it's elliptical. And the most important point is this one will never close spontaneously. So this one, once we make a diagnosis, we just need to book and plan to operate on it. This one also has a higher risk of complication of incarceration. So it must always be repaired surgically. So the most important thing we must see on this slide is this hernia will never close spontaneously. So much about the abdomen and the inguinal area. The other problems that we face in our day-to-day practice, in our general practice and everywhere, is the head and neck lesions in pediatrics. They are quite confusing. So I will try to put up some pointers that you can make it easier for all of us. So most of these are congenital, they are inflammatory, they are, in some are even neoplastic. So if you divide them into this, it actually makes them easier. So if they are congenital, we'll go through the list of the congenital one. If they are inflammatory, we'll go to the inflammatory ones, then the neoplastic, we'll go to them as well. So what do we use to identify them? The location is by far the most important to make the diagnosis. There are midline swellings, then there are lateral swellings. I think if we try to divide them into triangles, we make them more complicated. But if we just keep to the midline swellings and the lateral swellings, it will make our life very, very easy. So if it's in the midline, the differential diagnosis is there. I admit it's the differential diagnosis that I gave there is also a bit flashy, but the most important thing that we must learn from this talk is that the thyroglossal cyst and the sublingual dermoid are the ones that are most common on that list. The third that we may see is a lymph node called a Delphin lymph node. The other things making it to that list are very rare things that we almost do not see. The lateral swellings include adenopathy, swellings from the thyroid, the salivary glands, and the branchial cysts, as well as what we used to term the cystic hygroma. In newborn patients, it may be also what is called a stenomastoid tumor. There are lots of vascular lesions that may appear on the neck. They could be lymphatic. They could be from the veins. They could be also from the capillaries. And the list is very long, even with soft tissue tumors. So I'll start with the adenopathy. Adenopathy is by far the commonest of the neck masses. I'm sure all of us see these every day in our practice. Some have been there for some time, but the mother just palpates it once, and the next thing is they are batting the child coming to you very fast because this is the first time they've seen this node. But most of these are fairly common. So they are mainly reactive nodes after viral infection, after even the ringworm infection, and most of them are self-limiting. So for these, the guideline is to, if they need antibiotic, treat them on antibiotic review in 3 weeks. Most of these would have resolved, and they are usually found in the 2 to 10 year age group. They are found in all sorts of areas around the neck, around the EM. But the bottom line is they are self-limiting, and most of them will resolve. So we must not rush to see. When we see one, we run to do it. We already want to biopsy and get excited about it. We must give it take the history of the patient properly, see if this is not like from a tonsillitis, if this is not from an infection in the mouth, from something on the tooth, or an injury in the mouth, and manage them accordingly. The differential causes of adenopathy will be non-specific hyperplasia. They may be suppurative, they may be from allergies, and mycobacteria is everywhere. It wants to confuse us everywhere we go. So mycobacteria, we must also think about. HIV and lymphomas are also what we must think about. But this will obviously get together with a good history. So there is some group of patients that present in the submandibular region with a marked swelling, which was anomalously named, like it confuses that if we call a heart attack is linked with an angina, and then now on the neck we got an angina. Now it does not make very good sense. Now that swelling under the mandible is called a Ludwig's angina, and it can start after upper respiratory tract infection, an injury to the neck, or even a scalp infection. And this infection, most of the time, is subtle, but if we delay treatment, it can become very big and even require airway management when it is closing the patient's airway. Then the chronic ones are usually viral. They can also be from toxoplasmosis, the granular matter from TB, atypical mycobacterium, and also from things like the KT scratch. Like I said, most of the time the treatment is antibiotic treatment for 7 to 10 days, and check if it's resolving, then we are happy. If it's not resolving, then we start to look for other things, loss of weight, night sweats. If it's the size is increasing, are they also the consistency of these lymph nodes? Are these hard, immobile, matted lymph nodes? Are they associated tumors? And also the general condition of the patient will also give you some hints. And then this is when you think about doing a biopsy and getting a histological diagnosis. The next group of neck problems is the branchial cleft anomalies, which are remnants of the branchial apparatus, which develops between the 4th and the 8th weeks of the embryo life. They can present as fistulas, sinuses, as cysts, or they present, most of the time, they present as recurrent abscesses in children. If you've got a patient that you are continuously draining an abscess on the same site, somewhere around the neck, then you are looking at one of these branchial cleft anomalies, most probably. They are usually age dependent and rarely present before 10 years is a bit too much, before 6 years. And all of them, they lie anteriorly to the sternocleidomastoid. The commonest one is the second one. This is actually the one that we will see in practice. The first, the third, and the fourth, you may not see them most of the. The second one is the one that you see most of the time, and it's usually like in those photographs on the right of the slide. The one that you tend to see is the one on the bottom. That is about at the junction. If you divide the sternocleidomastoid muscle into thirds, it's about at the junction of the middle and the bottom third. And like I said, it may present as a fistula, as a sinus, or as a cyst. So, like I said, if you've got a patient with an abscess that you've been treating 3-4 times and draining the abscess, it comes again, then it's what the culprit is likely to be this one. And so the treatment is to then, if there's an intercurrent infection, is to treat the infection and wait. When the infection is gone, then you operate on it, track it, go onto the tract. At times the tract is very, very long. You would have to use what is called a step procedure from the initial incision. You track it until as far as possible, then make another incision and follow it up until the end. If you do not do this, you are it will still continue to follow your patient and follow you as well, because the patient will keep coming to you until a point that they go for a second opinion. So the management is complete excision. If, like I've already mentioned, if there is an infection, we want to wait and wait treat the infection and then operate later. The other common anomaly we see is the thyroglossal duct cyst. If we remember well from the embryology of the thyroid starts from the foramen cecum and then it moves down. By the 24th day of life, it has moved down. And what we must note there is the relationship to the hyoid bone. They are very, very close in their embryonal life to the point that when you have to operate on a thyroglossal cyst, you have to track its path through the hyoid bone. If, like in the previous condition, if you do not do that, the recurrence rate is very high. So you have to follow the cyst, even chop off part of the hyoid bone that the cyst goes through, and then you follow it to the floor of the mouth and end up there. This is called the cyst trunk procedure, after the gentleman who invented it very little has changed from when he invented it in 1920. People have tried to use some other methods, but no method has been found superior to this guy's method. He must have been a very brilliant guy. So how do we differentiate this from the other things that I've mentioned? Usually it's located in the midline. This slide, I'm sure for some of us, it has been there when we were doing our surgical exam. How do we identify that this is a thyroglossal cyst? It's by protruding the tongue or giving the patient a glass of water to drink, then it moves with it. When the tongue moves, then so the diagnosis of it is quite easy. The problem with this thyroglossal cyst is in about 1% of these patients, this may be the only thyroid tissue that the patient has. So we need to do a sonar to see, does this patient even have the thyroid tissue on either side of the neck. We also need to differentiate this from a dermoid cyst, because the dermoid cyst, we're just going to shell it out. This thyroglossal cyst, we are going to have to do that cyst trunk procedure and follow it until we go to the floor of the mouth. So the management of it is to do the cyst trunk procedure. Why would we do the cyst trunk procedure? It's because it presents with a recurrent infections. There's also a risk of adenocarcinoma. It's very low risk. It's mentioned in the region of 1 to 2%, but we don't want to lose even those 1 to 2% of patients. So these must be taken off. Most of them, these unfortunately you see them after they have been presenting with an abscess many times, and the IND many times, and then the operation there is a challenge. It's through a lot of scar tissue, and the recurrence rate there is less than 10% if the operation is done very well. This next slide shows one of the most disfiguring kind of malformations that we see on the neck, which previously was called a cystic hygroma, but the terminology has changed. It's usually a cystic lymphatic malformation that presents like this. The patients that we see in the outpatients, it's very traumatic to the mother to have a child with such a big mass on the neck. Wherever they go on the public transport, everyone wants to look at them. And in these days of social media, it's not even surprising that the guy sitting behind this mother is taking a photo and making the poor baby go viral. And so you see these mothers, you feel pity for them. They try to dress their babies in such a way that no one sees that this baby have got this huge malformation. But fortunately for these babies, there is quite a lot of treatments that can be done. Firstly, some of these will resolve. So in the first year of life, you could leave this baby if it's not too dramatic. So it can resolve. If it's too big, after imaging, the commonest solution is to put a sclerosing agent. The most common now is to use doxycycline as a sclerosing agent. For some, even if you use it once, it totally resolves, and that's it. It's done. For some, you need a couple of times with the sclerosing agent, and then surgery later. Surgery is not very easy for this kind of patients. We appreciate that the neck is very small in those patients, and you are going to end up in the trachea there or the esophagus. If you want to cause vascular drama, you can choose the carotid artery, or you can go into a vein if you like. So the surgical totally there is almost always out of the question. Using a sclerosing agent and then using surgery when it's small would be more advisable. Besides the lymphatic malformations, there are also arteriovenous malformations, capillary malformations, and there are also there's a wide range of congenital vascular malformations which may be on the neck, in the axilla, and the 75% are in the neck. That's why we brought the issue up here. Otherwise, some of them are in the axilla, some of them are in the rest of the body. Their treatment algorithms are very different. You would remember some of them you are treated with propanolol, some of them do not respond to propanolol. You need to be sure which one is going to respond, which one is not going to respond. So the imaging must be done so that you are sure what you are dealing with. And because that site has got so many things, so you may there is a wide range of symptoms. It could be from the pushing onto the esophagus, pushing onto the trachea, that they can present with. It's a whole lot of things, or they can even be protruding into the chest, so they can also present with the chest symptoms. So I've already mentioned all those things that we may use to treat. The last one would be the stenomastoid tumor. This is the name tumor is an anomaly because this is not actually a malignancy. Something? So this usually presents as a hard mass within the stenomastoid muscle of a neonate leading to a torticollis. I'm sure the pediatricians are the ones who first see this kind of patients. It also presents to the general practitioners, and it's when the mother notices that the child's neck is on one side, obviously they will present the same day. The cause is largely unknown. I'm sure they will be disappointed when they see that we don't even know the cause. And but most of the time it's just physiotherapy on this patient, and it resolves. The differential diagnosis, of course, will be some other physical anomalies like vertebral anomalies, astigmatism, painful neck masses. These can be diagnosed if we take a good history and also in the investigations. So physiotherapy resolves 90% of these. If they are not resolving, that's when we need surgery or. But otherwise, most of them are going to resolve. So I will briefly talk about the parotid gland. Mostly, we see babies with parotid infections. Mostly, we agree it's moms, but a very small fraction may also have hemangiomas. It may also be a bacterial infection. But for the one that is not resolving, the malignancy must be always at the back of our minds. The ranula, I will mention it very quickly. It is a cystic sublingual swelling that we see under the tongue. And it usually appears bluish and very dramatic to the caregiver. And unfortunately, the treatment is simple muscularization. Although if not done very well, they may be faced with a recurrence. Okay, so in a nutshell, this is what I had to share with you tonight. Okay. Yeah, we'll entertain any questions at this point.
Okay. Thank you, Dr. Moforo, for such an exciting presentation. Let me just go over the comment side to see if we have any questions. I think the slides are going to be shared. There's a comment from Dr. Florence that was saying your slides aren't visible. I guess they'll be shared through the relevant portal. And then there's a question from Dr. Ngoyi. The first one reads, does a diagnosed uncomplicated hernia in general needs surgical intervention? That's the first one. And then number two, it says, or it can wait 4 years until it develops into complications. All right. And then the second paragraph reads, until what age do I advise parents to wait for his firstborn boy with a bilateral undescended testicle? A scan was done and the two testicles were seen still up there the boy is now turning 3 years. I'm not sure if the question is quite clear. All right. Okay.
This first thing, was it Inguino or if the first question is about an inguinoenia, the strategy with the inguinoenia is in the first year of life, the risk of complication is very high. So the recommendation is as soon as we see that the patient is going to inguinoenia, we must operate on it within the next 2 weeks. We must not wait for it to get complicated because, like I explained, the complications include also the patient losing their testes. So it's a very high stakes there. So we do not want to wait until we develop a complication. This patient with the bilateral undescended testes, we must know. I have mentioned that the recommendation, the current recommendation is to repair them around between 6 months to a year, because if we delay them longer than this, then the risk of malignancy rises, the risk of infertility also rises, the risk that hormonal secretion is going to be malfunctioning also rises. So the recommendation is to operate them within the first year of life. Not like I mentioned, in the first 3 months, there's a very good chance that they will descend. But after 3 months, they are not going to descend. What we are essentially waiting for is for the structures to become visible, so that we can clearly see them and operate safely between 6 months and a year.
Okay, thank you, Doc. I don't see any other questions. At this point in time, I'll hand over to Dr. Matunjwa for a quick announcement on the next CME session. Thank you, everyone.
Good evening, colleagues. There's a raised hand. Basically, it's an announcement that the talk that was built to be on the 6th has been pushed forward to the 5th. The one on neurosurgical awareness by Dr. Shongwe from EPH. It's starting at 6 p.m. instead of the 7 in the morning. That was the initial time slot. Yes, that's the only announcement I have. Thank you, colleagues. So it's Tuesday, 6 p.m. instead of Wednesday because it's a holiday. Thank you.
Thank you, Doc.